Good morning, everyone. We're happy to have you all here for our June session of the West Region Learning Collaborative. My name is Anshe Hall Everett. I'm proudly representing the wonderful California Prevention Training Center, but I'm also joined by my amazing colleagues, and that's from Denver Prevention Training Center, as well as San Francisco Department of Public Health. So we're so happy to host you all here today for this session. If you don't mind, just so we know who's in the room, right? Just feel free to put in the chat box, your name, the jurisdiction you represent, or even your organization. That would be so great. Next slide, please. And I'm trying to fix my ratio so I can get this right, but never mind. Okay. So this is pretty much our learning objectives for today. We're going to cover the following. What we're going to do today is introduce the purpose of data to care, or pharmacy data to care, I should say. Review of jurisdiction that has begun the implementation of data to care, pharmacy data to care. And also maybe identify 2 opportunities to partner with state pharmacy boards and local pharmacies for the use of sharing pharmacy-based data to strengthen existing data to care activities. Next slide, please. And while I'm doing it, let me, before we start, let me just put this in the chat box so you all can have this. Just let you all know where we're working from today. If I can get it in the chat. There we go. So these are the articles that we'll pretty much be referencing today during this learning session. So feel free to do that. But again, this presentation highlights what has been captured from the work that's been published from these articles. All right, go ahead, Sophia. So pretty much what we're, when we're thinking about pharmacy data care and what it is, prescription data are a source to identify persons with HIV who have stopped filling antiretroviral medications and who are at risk for falling out of care. So when a pharmacy receives a prescription, a variety of data are often entered into the pharmacy management system to process the prescriptions, such as patient information, prescriber information, drug information, and third-party payer. Next slide, please. But because most ARVs are prescribed as a 30-day supply of medication, pharmacy claims can be used to identify persons who are not filling their ARV prescriptions on a monthly basis. And so tracking ARV claims data can therefore be just more of a real-time indicator of poor adherence, as well as can signify poor retention and care. Next slide. So when we think about the data elements as pertains to pharmacy data to care, this data to care strategy can use pharmacy claims data from the following. It can be used from pharmacy databases, which kind of gives more of the broadest access. Also from an insurer, which can be also Medicaid or commercial insurer, or even other sources. Pharmacy-specific fulfillment data can also be used, particularly if from a retail chain or HIV specialty pharmacy with a large catchment area. And so at minimum, the database will need the following, patient identifying information, which looks at the name and contact information of the patient, the name of the antiretroviral medication, or even the national drug codes that may be attached to that, the days of supply for each prescription, the prescription fill date, as well as the prescribing provider. And then when we think about the reverse out date, which is really the date that indicates when the medication was returned to shelf because the prescription was ordered but not picked up by the patient. This is useful additional information because for the patient, when no ARV claims, this date also can indicate that a prescription was ordered by a prescriber. Next slide, please. So here are a few when we think about the operational steps and decision points. So when considering a potential pharmacy claims or fulfillment database, health departments or programs, right, data care programs should determine the number of persons with HIV within the department's jurisdiction who are covered by the database. And so the initial step of a data to care, pharmacy data to care initiative would pretty much use that pharmacy data to identify persons with HIV who may fail to fill their ARV prescriptions. And then the first decision is usually whether around to identify persons with a history of filling ARVs, but then who may have stopped. Or when we think about, to identify persons with a known diagnosis of HIV, but no ARV claims. And so if your program decides to start by identifying persons with a diagnosis of HIV and no ARV claims, then this is where we may want to think about using some type of like supplementary database, such as like our HIV surveillance or even medical diagnosis claims, which will be needed for information on HIV status. And that can definitely support that when we're thinking about how do we strengthen, right, pharmacy data to care claims, or if we look at folks who fall out of care who may not be captured. Lack of ARV prescription claims could indicate a failure to fill prescriptions, but it also could indicate like a variety of other situations. And this can be such as like patient disenrollment from insurance, if using an insurer-specific database, migration to an area that may not be covered by the database. There can also be situations where there's a change of filling pharmacy or pharmacy network. So, if you're using a pharmacy or pharmacy network database, that may be an issue. There's also cases when we think about one who may be incarcerated or those who may have passed on or death. And so therefore, programs should also consider developing a strategy that draws upon multiple data sources to classify persons as either filling or failing to fill prescription. And other data sources might include, our ADAP database, also our like state pharmaceutical assistance programs, the patient assistance programs that we often see from like pharmaceutical companies such as like Gilead, or even like vital records. So these are opportunities where you can get those additional information as need be. Next slide. So pretty much like health departments will also just need to decide when and after identifying the persons who have failed to fill ARVs, like when to intervene and at what level to intervene. And so one strategy to intervene early with the low intensity first line intervention may be like calling persons just to remind them to pick up their prescription or medication. Just think about the early intervention and considering like ways to like risk the viral rebound shortly after interruption of the therapy. So what strategies can we use that can be easy, but also allow for us to really be effective within that? Next slide. So when determining how early to intervene, health departments should consider if intervening within the specified time frame, maybe somewhere between 2 weeks, 30 days of failing to fill. And that's usually what's practical given the anticipated number of persons who might fail to fill during this timeline and the amount of resources that may be required within that. Also, the health department can collaborate with external partners as a way to lessen the workload. So for example, the health department might work with the fill-in pharmacies to conduct the first line intervention of like contacting folks to let them know that, hey, your medication is here, or your prescription is here. Here's an opportunity to pick it up, or that good stuff. For persons who continue to fail to fill after that first line of intervention, maybe thinking about ways of like other interventions as maybe like, what other support that can be there. So what can we use in regards to like getting our other staff persons involved, thinking about maybe like a DIS person or a patient navigator who maybe can support with that. If there's like any sort of like clinical team that you have, or how maybe get the provider to be involved if there's a relationship with the provider, and thinking about how they maybe can contact the individual and being able to come in and pick up the prescription. But again, this is another way, right, of thinking about what's your team that's needed to make this pharmacy data care effective. But again, just thinking about the timing of this and also what resources are needed is definitely going to be critical to that. Excuse me. And then also just thinking about strategies in regards to the time interventions that are 30-day intervals. Think about the person who has failed to fill their ARV prescriptions by 30 days. What does that look like? Maybe a person who may have failed to come in after 60 days. What does that intervention may look like? Or even up to 90 days, what an intervention look like? So really think about the time frame in regards to like ways of implementing your pharmacy data care strategy. Next slide, please. So this slide here highlights more so of a strategy that's being used when it comes to pharmacy data to care. As you can see, there are various data sources here. There's the individual pharmacy, there's the pharmacy network, there's the insurer, there's also the pharmacy-based management system. There's also claims aggregate data that's all there. And so what they did was they used like 1+ as a way to show, hey, this is a success, 2+, major success, 3 success, like it's super effective. And as you can see from here, the individual pharmacy usually has a greater success than the other 4, but there's still success in the other 4. But I'm assuming from the individual pharmacy, there must be a relationship with the health department and that local pharmacy in a way to allow that success to really happen. So again, this is the option of showing like what ways you can use this like to capture like pharmacy data information and how you can use that to strengthen your data to care activities. Next slide. And then this here is just more so of a case study that was done in Detroit. As you can see, they had records of about 170 individuals living with HIV, and that was their study. From here, what they began to see is when through their pharmacy data care program, they were able to capture, right, those who were able to fall out of care. They used various lines of interventions, right, to be able to capture those folks who may have missed some days of going in to pick up their prescription. But what they were able to do through that engagement of this pharmacy data care program is that they saw that there were fewer days missed in those who were picking up medication, but also they saw an increase in adherence, right, to medication adherence. And as a greater impact, there was a reduction in viral load too. So they began to see a relationship between one's own viral load and also having the intervention aligned with getting folks, right, engaged in picking up their medication with their local pharmacy or pharmacy network. Next slide, please. So there are some challenges when it comes to this. The first challenge is getting access to a real-time or near real-time pharmacy claims or fulfillment database. You know, most third-party aggregate data, such as like, you know, IMS Health or Truven Health analytics are not timely and do not like contain patient identifying information. So they may not be as useful for patient management, but there's also like access to claims or fulfillment date. They may not require establishment of data sharing agreements, and therefore that there may be an associated cost, right, to be able to have access to that or be able to have some sort of medical record keeping system, right, to be able to support with the pharmacy claims and fulfillment dates. There's also, depending on the databases, you know, persons who fill ARVs through ADAP may not be identified in some states, or pharmacy databases manage so may not be captured in those states, and it may not be captured within those pharmacy databases. So thinking about other ways to be able to like, how do we find ways to like capture those who may miss picking up pharmacy prescriptions or who may be transferred and got a new insurer, what have you, like what mechanisms or what systems can we put in place if we're not able to capture those, if the pharmacy database may not capture those who enrolled in ADAP. There's also, in thinking about this, that if a person like change insurance or maybe lose insurance, you know, they may not be able to follow within the database. And this can be mitigated by using some type of data from pharmacy databases, which contains claims from multiple insurers and even some ADAP programs. So really doing the homework of like your state pharmacy board or your local pharmacy and getting a feel for their databases and what they use and how much access they have. And even if they're partnering with like the ADAP programs, there may be opportunity there to think about what collaboration look like to be able to have ADAP data captured within those pharmacy databases. And excuse the background, I live near a downtown area, so forgive me with that. So within one pharmacy network, you know, prescriptions can be tracked across partner pharmacies, such as a retail pharmacy. But however, if a patient switches pharmacies to another chain or independent pharmacy, you know, again, the previous refill history remains within the first pharmacy. So figuring out how do we be able to capture that information? What does that data share look like with an old pharmacy to a new pharmacy when those things happen? And also, if a pharmacy-specific fulfillment database is used to implement the project, Persons who fulfill outside of the pharmacy network might wrongly be labeled as failing to fill the ARV prescriptions. So in addition, the program would not work well for persons who have prescriptions with automatic refills through a mail order pharmacy. And so these persons would need to be counted as filling prescriptions despite there being no active patient involvement in doing so. And then also, there may be the challenge around like community engagement. You know, folks may find that the information you're capturing may feel intrusive. So again, how do we begin to build that trust within communities and thinking about ways to also capture like, hey, who is your local pharmacy? And is it okay if we're able to, you know, engage your local pharmacy to make sure we're able to capture your information so we can best support you and getting always ensuring that you have, you know, medication or prescriptions that's needed. So again, those are just some things just to think about. Next slide. So in all of this, and again, this is just more so highlighting what we captured from the articles that's been shared in the chat box. But again, just tracking prescription claims can be a near real-time method to identify persons with HIV who fail to fill ARV prescriptions and who are at risk of falling out of care. And so a data to care model using pharmacy data to care, using pharmacy data may help to minimize treatment interruptions, but also improve adherence and viral suppression and keep the person with HIV engaged and retained in care. And next slide, please. So we had to stop here and we see there's some questions in the chat box. And I think that these discussion questions can also help with supporting some of the questions that we have in the chat box. But these are just some of the discussion questions we have. Like, what is your current relationship with the local pharmacies? And what role do they play in your existing HIV prevention and care services? How can you use existing relationship with pharmacies as an opportunity to gain access to pharmacy-based data? And also what resources are needed to support with implementing data to care RX or pharmacy data to care? So I'm gonna pause here and see what we have in the chat box. So that way we can get a discussion going. I see there's a question from Dr. Bloom and asking would jurisdictions need to pay for access to these databases? And, oh, Greg, you were gonna.
Well, I think that that question came up specifically when you were on the side where you were talking about medical databases, and I'm not sure, Dr. Bill, if that's specifically what you meant. Definitely any of the systems like LexisNexis or the one I can never remember the name from that comes from a credit monitoring service that seems to be really effective. Those definitely are subscription. I believe that in the two programs, the Detroit program and the Seattle program, I believe that the other databases were all what is accessible to the health department, excuse me, already.
Thank you, Greg. And let's hear from some folks in the space, like in regards to your current relationship with your local pharmacy. What does that look like? What role are they playing in your current HIV prevention and care strategies or services?
Actually a good time to just ask if anybody is using pharmacy data at all for their data to care program at this time, or has interest in doing that.
Hey, Greg, and actually this is Ty from Denver. We haven't heard of jurisdictions or programs using it, but it seems like it would be something that would be very useful, especially for programs who are doing rapid start ART or things like that.
Thank you, Ty. Yeah, just from reading over the research, what's currently out there and looking at what's been done in both Seattle and Detroit, there have been some great successes from this. And I do think that is another strategy, right? When we think about opportunities to re-engage folks into care, when we think about this as being, what is this like under the treat pillar of EHE? And how can that, right, be an opportunity, right, to leverage what we're currently doing to be more effective in meeting that pillar? Jesus, I see your hand up. Go ahead.
Yeah, thanks, Anshay. I think this is such an interesting topic. I'm barely learning about it. Before I was a CBO provider, I was at a CBO doing navigation, and I would sit in meetings with leadership in these organizations, and then we talk about the business of providing services, right? And so there was a lot of conversation about leveraging 340B to keep the business running. So I think that combining this data with the business is really interesting. And just me thinking about if I was back in the CBO, I would use this new kind of lens to like make really convincing grant proposals. Like, this is the model we're going to follow. We're going to use this new kind of data to track prevention and treatment and et cetera. So I think this is fascinating. And if CBOs kind of like knew about this, they could really implement it to continue their business and also help with their proposals.
Thank you, Jesus. I agree. It's interesting. I know that there's much work when we think about the relationship with pharmacies, health departments, or HIV programs as pertains to PrEP. And what does that look like? So it'd be cool to see what successes, lessons learned from that can definitely be an opportunity when we look at ARV prescriptions and the sharing of databases or the sharing of data between health departments and pharmacies when it pertains to ARVs. Any jurisdictions? Oh, go ahead, Greg.
Dr. Bloom had a question also about if Kaiser, that people fall out of losing their Kaiser insurance, then fall out of care, and wondering if the Kaiser databases are included in this. And one of the things, like the two programs, the Detroit program and the Seattle program, operated slightly differently. The Seattle program was really using their internal, so they really were focused on the clinics within University of Washington and the pharmacy that's internal to that. Whereas the Detroit program worked with a wider range of pharmacies through, pharmacy networks, et cetera. And I don't know, I don't know the answer about Kaiser, if they're, accessible to health departments in areas that have Kaiser or not. But so there were two different models that were used. And, Kaiser could be its own, data to care pharmacy, data to care program, because it's so big and has the internal pharmacies.
This is a new hand or is it the same hand?
Same hand, let me put it down.
Oh.
So just sort of in some transparency, CDC asked us to focus on this in last year 4, and was it 3 or 4 at launch? I can't remember. 3 and into 4.
Yeah, 3 into 4, yeah.
And because there was a lot of interest, a lot of excitement about it, and the only 2 programs that anything has been written up about that we could find or that CDC even knows about are the Detroit program and the Seattle program. And when we recently contacted Dr. Golden at University of Washington and about this, he was not enthusiastic, put it that way. He was feeling like that it maybe wasn't even worth the effort. Whereas I think what needs to be weighed there is if this helps, what is the threshold for the amount of effort that goes into how many people get maintained into care. The Detroit program seemed to be a little bit more enthusiastic and successful. And then they were working with NASDAD to create some sort of a toolkit for health departments and outside of CBA, this is separately with NASDAD. And it appeared that NASDAD has kind of let that kind of go aside, that nothing has really happened with that. So, you know, part of what Anshi and I have been, and we've been in discussion with our CDC SME and our program with Sperry about, you know, do we go forward with this? Do we want to push this? Because we were planning on doing a summit or an institute on this, and it feels like there may not be a lot of interest in it, but we would be happy to do it and thrilled to do it if people had an interest. So that's part of what we're trying to do today is gain a little insight in that as well. And like you said, Ty, you haven't really heard of programs doing it. The other thing I do want to quickly bring up is in Seattle, they were also looking at this for PrEP maintenance. So using the pharmacy data for making, you know, helping make sure that people stayed on PrEP. So that's another sort of aspect of it.
Are maybe any of you folks on thinking about what this could look like, even from thinking about PrEP and PrEP engagement, what that may look like, as opposed to in regards to partnering with pharmacies and sharing of the databases to ensure the retention of PrEP. And we have Andrew here. Yes, I'm the PrEP navigation manager at DAP Health, and this is a strategy I've thought about. Yeah, and Dr. Bloom says, seems like a great potential tool for PrEP in combination with navigator support. Okay. Well, you know, please let us know, keep us posted again, as Greg mentioned, right? This is something where we want to definitely use this as a way to highlight what's currently out there, since this is rather new, this particular strategy, and there's still studies being done, currently just 2 at this moment, but still, this can be another opportunity, right? When we think about the treat pillar, what strategies can we use, what ways to leverage, right, our current data care activities, and how can we, right, use pharmacies as that opportunity to do that? And again, thinking about what collaboration could look like from that. And we share with some of the challenges that are currently out there. So even when thinking about those challenges, like how do we work around that? Who else should we bring to the table as a way to think about ways to strengthen what we're currently doing, or be able to make what we would like to do in introducing the pharmacy aspect of this to definitely strengthen what we're doing. Any other?
It has been used with other, other conditions as well, with some success. There's a number of articles about adherence. I think mostly the ones I've seen have been around for diabetes, and some for heart conditions as well. But it's, again, there's only that we know of 2 that have even been written up about for HIV.
Thank you. Thank you. Well, we don't want to force nobody now to respond or share anything. But again, this is an opportunity, another opportunity for us when we're thinking about ways to leverage what we're currently doing. When we think about the treat pillar, what ways can this be used as, how can this activity be used for that? So again, this is just another strategy that's there for you. We want to just get a feel if folks are interested, right, in additional TA, as Greg mentioned, we were looking at we proposed doing a pharmacy data care summit, but we want to gauge interest if there's an interest in it. So if it's not, that's good, that's okay. But if you are thinking about, well, I would love to explore this a little bit more, feel free to reach out to us. We wouldn't necessarily be the ones doing the actual TA. We actually have as some subject matter experts who can come in. So folks from Detroit and Seattle who can be able to speak more about their respective programs and the successes. And that can be an opportunity right there just to learn more.
We're also asking for assistance from the CDC CMEs like Dr. Bird and Dr. Hall, who's our CME on this, SME, sorry, on this topic.
Well, all right. Well, that concludes then this session. I mean, you can push the next slide if you would like to, Sophia. But are there any remaining thoughts or questions or feedbacks that pertains to this June session? This was rather a quick June session, but just any remaining thoughts, questions, or feedback you all would like to offer.
I'm going to share the evaluation in the chat. If people
Thank
could please.
you.
Yeah.
Well, in the chat box is the link to the evaluation. Please complete the evaluation. This is another way to help us know what we can do different, what content you would like to see, even just the style and what we facilitated today. But definitely feel free to complete that. And yeah, we thank you all for today.